Welcome, everyone, to another deep dive into anatomy. Today, we are looking at the highways of the upper limb, specifically the cephalic and basilic veins. Think of these as the primary transit routes for blood heading back to the heart. Why does this matter clinically? Because if you can't find these, you can't draw blood, administer IV meds, or place central lines. It is the literal lifeblood of clinical practice.
That is a perfect framing, Con. And for the listeners, let's keep it high yield for your boards. The cephalic and basilic veins originate from the dorsal venous network of the hand. The cephalic vein, derived from the Greek kephale, meaning head, travels along the lateral aspect of the forearm and arm. It is a surface-level vessel that eventually dives deep through the clavipectoral fascia to drain into the axillary vein.
I always tell my students to remember the cephalic vein as the lateral superstar. It stays superficial for a long time, making it easy to spot on a fit patient. But it is also famous for being wiggly during venipuncture. Now, Sarah, let's contrast that with the basilic. It is the rebel of the group, right?
Exactly. The basilic vein travels on the medial side of the forearm and arm. Crucially, it does not stay superficial forever. About halfway up the arm, it pierces the deep brachial fascia. This is a high-frequency exam point. Students often forget that the basilic vein runs with the medial cutaneous nerve of the forearm. If you are doing a nerve block or a surgical approach here, you better watch out for that relationship. That is a great warning. I always think of the median cubital vein as the bridge between these two giants. It sits right in the antecubital fossa. It is the doctor of choice for venipuncture. Why does this matter clinically? Because it connects the two systems, allowing blood to move from the cephalic to the basilic, and it is usually tethered down by the bicipital aponeurosis. That aponeurosis is like a protective shield against your needle going too deep into the brachial artery underneath. It gives you a little margin for error. I love the shield analogy. It is essential to emphasize that the median cubital vein is the most common site for phlebotomy because it is superficial and typically larger. On the boards, they will often ask about the anatomy of the antecubital fossa from medial to lateral. Remember the mnemonic TAN for tendon of biceps, artery, the brachial artery, and nerve, the median nerve. Wait, it is actually TAN for tendon, artery, nerve, but the vein is sitting right on top of that floor. You have to be precise. Right, and if you miss the vein or are too aggressive, you are heading straight toward that brachial artery. That is a clinical nightmare. So why does this matter? Because knowing your anatomy is the difference between a smooth blood draw and an accidental arterial puncture, which causes hematomas and a lot of unhappy patients. Absolutely. Also consider PICC line placement. When we place peripherally inserted central catheters, we often choose the basilic vein over the cephalic. Why? Because the basilic vein provides a straighter, more direct path to the axillary and subclavian veins, whereas the cephalic vein has a sharp torn near the shoulder that can make passing a guide wire very difficult. That is such a practical tip. It really highlights how anatomical structure dictates our procedural success. So if you were looking for a quick draw, go for the median cubital bridge. If you were looking for long-term venous access, you were looking at the medial route of the basilic. It is all about choosing the right road for the right destination. Agreed. To summarize for our listeners, the cephalic vein is lateral, superficial, and hooks into the axillary vein. The basilic vein is medial, pierces the deep fascia, and provides a direct, straighter path for central access. And the median cubital vein is your primary target for routine phlebotomy, safely positioned over the bicipital aponeurosis. Master these paths, and you have mastered 90% of peripheral access issues. Spot on. Keep these pathways in your mind. Visualize the anatomy, and you will be much more confident during your clinical rotations. Until next time, keep studying hard. Work in anatomy lead to great doctors, to excellence.